Hello, my name is Chris Gilmore. I work as a specialty doctor for the Acute Care at Home team, based in Lurgan Hospital. The title of my project is Improving the Referral Process to the Acute Care at Home team from the Emergency Department and the Acute Medical Unit of Craigavon Area Hospital. The Acute Care at Home team is a relatively new team which provides acute medical care in the patient's own home, in the residential or nursing home, which previously would only have been available in hospital. The main referral source is from the patient's general practitioner, with an aim to prevent attendance at hospital completely, but it also enables patients who have already been admitted to hospital to be discharged earlier to complete their treatment at home. Referral from the acute medical unit may reduce the patient's inpatient stay, and referral from the emergency department may prevent admission entirely. My project aimed to increase the number of referrals both from the emergency department and the medical wards, and also to ensure that suitable patients were being referred. The projected benefits of my project were to improve the ease of referral for the medical staff in the emergency department and the acute medical wards, to increase the total number of referrals, thereby hopefully reducing unnecessary admissions, and improving the referral process by providing a standardised method of referral and triage. Due to the relatively low numbers of referrals, I looked at the referrals over a 3-month period, from the start of March to the end of May 2016. The total number of referrals were 49, of which 59% were accepted. Unfortunately, 41% were not accepted. This slide shows the reasons why patients were not accepted. As you can see, in 40% of the occasions, there was a medical reason. This equates to 8 patients. In 30% of occasions where the patient was not accepted, the patient was not living in the geographical area covered. This again equates to 6 patients. In 15% of the time, there was no capacity from the service, and that equates to 3 patients. And again, in another 15% or 3 patients, it was due to patient or carer choice. As this service is an optional service, some patients and carers wish to remain in hospital. At the beginning of the project, I surveyed potential referrers to our service. Most were aware of the service, but there was some variability in their knowledge. Most were unaware of all the services that we provided. Areas highlighted by the survey were a need for more visibility and awareness on the wards and in the emergency department, a clarity on referral criteria and exclusion criteria for the service, and the area covered by the team. This is a difficult area as the area we cover has been expanding. There was also some concern expressed about potential delays to discharge from the emergency department. For example, we would be unlikely to meet the 4-hour target to discharge. This is mainly due to issues outside our control, for example, arranging transport home. This slide shows a cause and effect diagram of the referral process, also called a fishbone diagram. As you can see, there are many interrelated reasons which complicate our referral process. However, GPs often comment they value the opportunity to discuss referral with the accepting doctor and receive a decision immediately. Following discussion with the other members of the Acute Care at Home team, we felt we needed to improve the information provided to referring staff in the emergency department and on the wards. The posters and information we had initially produced were really for use by general practitioners and were not specific to the wards. Using a plan, do, study, act process, I developed a poster specific to the needs of the emergency department and the acute medical wards, answering the specific questions which the survey had identified. This is a copy of the poster I produced. It clearly shows it has been produced specifically for the hospital referrals. On the left side, inclusion and exclusion criteria are clearly set out. On the right, referral by telephone with a single telephone number for contacting the team, and clear times of operation. The geographical information at the bottom is a little complicated as our service is expanding and the area is likely to change. However, I have suggested that if someone is in doubt, they contact the team for clarification. This is a simplified process map of the referral process. Referrals are taken from the emergency department and the AMU on a single extension number. The receptionist takes the referral details and passes these directly to the acute care at home team doctor. The doctor, when available, makes the triage decision in consultation with the team immediately, with an aim to assess the patient within 2 hours. I've developed a short PowerPoint presentation for the medical and nursing staff in the emergency department and medical wards. This explains in more detail the information on the poster. As there's a rotation of junior medical staff every 6 months, I plan an ongoing cycle to update the plan every 6 months. Following the completion of my project, I re-looked at the referrals from Craigavon Area Hospital in the 3 months, September to November 2016. In comparison with the previous 3 months, it shows an increase of total number of referrals received by 12%. However, the referrals accepted and not accepted remained constant. The next slide shows the reasons for not accepting patients. From March to May, we can see that 70% were either not in the area or there was a medical reason for not accepting. This is reduced to 54% for September to November 2016. This slide shows the number of accepted referrals and those referrals declined due to capacity issues. From March to May, this was 65%, and September to November, it increased to 78%. This shows a higher proportion of our referrals were deemed to be more appropriate. And once capacity issues are addressed, we should be in a position to accept more referrals.